interest is pathogenesis of diabetes in India, NMR spectroscopy, and diabetic foot. Today's talk is on endocrine hypertension.
Thank you very much. It's a privilege to have my teachers and my colleagues over here, and wonderful my offshoots in medicine and sweet memories of medicine too when I look at Tambu David. So I'm going to be talking about endocrine hypertension, which is an area fairly vast by itself, has shown a lot of progress in terms of its diagnostic armamentarium, therapeutic armamentarium as well. So just to kind of reduce the amount of stress and catecholamine production right now, we'll start off with a little poem over here, which indicates the spectrum of adrenal disease that we are having as well. And this one category, as far as endocrine tumors or hypertension is concerned, is an area which involves a huge aspect of clinical medicine, goes through a lot of differential diagnosis, which we should always consider. Very often it is the more common conditions we should be thinking of rather than the exotic ones, which we will be looking at in this particular lecture. So the commonest causes for secondary hypertension among the following in an adult in order of merit are A, B, C, D, E, and there's no time to answer. You can yell if you want to. Your correct answer is, I beg your pardon, primary hyperaldosteronism. That's reasonably correct. So when you think about secondary hypertension, you have a spectrum of conditions over here. And a lot of them, perhaps for the adult physician, may be relatively more exotic, more pediatric disorders like the 11 beta and the 17 alpha hydroxylase deficiency. Conditions like the bottom three, the clinical condition dominates, even though you're more prone for hypertension over there. So it's the top three which are really more important, but also very important for you to understand that renal hypertension is far, far more common than endocrine hypertension. And the causes on the right-hand side of the slide are relatively more common as well. So yes, the commonest cause is primary hyperaldosteronism, endogenous Cushing syndrome, Theo, and in order of merit, this would be your case list that you should be thinking about over here. To the extent where primary hyperaldosteronism may be, depending on the population, depending on the center you're trying to diagnose it, about 5 to 15% of your patients who have refractory hypertension probably have primary hyperaldosteronism rather than systemic hypertension. So what is the size of the adrenal gland? Is there a normative? And when we try to make our diagnosis, we look at imaging, we look a lot at the CTs, we have to familiarize ourselves with the CT of the abdomen. This is normative data which has been taken from our center, and essentially the right adrenal is around 15 millimeters in terms of our median values. So I'm going to be focusing on this talk largely on catecholamine producing tumors rather than the other forms of endocrine hypertension over here. So here is a 54-year-old female who comes with recurrent episodes of headache, sweating, and palpitations, been on treatment for hypertension and diabetes for the past 13 years. Physical examination is normal, and these are her baseline biochemical and hepatological tests are also normal. So what are the diagnostic possibilities in this patient? So the fact is, once again, think common. In your practice as a physician, what are the diagnostic possibilities? What should you think about? First, when you see a lady who's this age with these symptoms, what should you think about? So as a second year medical registrar, you should be thinking of common things first. And therefore, all these are possibilities, but think of the commoner ones more likely being a diabetes patient. Think of hypoglycemia as the most common cause. So the differential diagnosis of hypoglycemia and the differentials are far more common than pheochromocytoma, are far more common than pheochromocytoma in its sense. And therefore, think of the other conditions first before you think about a pheo per se in these patients. For that matter, even menopausal symptoms can be fairly, devastating and may even resemble a pheo-like syndrome. And paradoxically, a proportion of patients may even have swinging high blood pressure in these situations. Yes, all the above are possible differential diagnoses over here. So the same patient has recurrent abdominal pain and sweating persists. The solitary blood pressure recording greater than 180 by 130 has been recorded, and the imaging has therefore been done. And we look, therefore, at patients who have these tumors. They tend to be on the larger side usually. They also tend to light up on the arterial phase. And this is what we are seeing over here, an arteriogram is positive. And you can also see over here the tumor, which also has areas of necrosis, cystic regions. It is typical of a pheochromocytoma. And this scenario with these symptoms, this is undoubtedly the diagnosis that you're taking. Let's go back to the past, wherein perhaps I may have been prepubertal at this point of time. Dr. Sheshadri's publication, the first ever publication from India on pheochromocytoma. And you can see over here, this is 35 patients. They used fairly cost-effective tests at that time. I'm not saying that I wouldn't refute the fact that we do not use vinyl mandelic acid anymore. But at that time, it is all down to this. And if you go back to the history, prior to the 1985, they were using angiograms and a few MIBG scans. CT scan wasn't there in CMC Velo in the mid-1980s as well. So that was how the challenges were, and we've come a long way since then. So what do these tumors produce? A lot of you and your outpatients are doing a number of tests. And you also need to understand the false positives and false negatives. Do they produce more norepinephrine or epinephrine? And herein lies the aspect of evolution. If you know that invertebrates do not produce a lot of catecholamines, they produce some other hormone called octomine. That's a seahorse on this side, and you have an orangutan on the opposite side. And the process of evolution involves, as you can see over here, the evolution of hormones themselves from the amino acids. And this evolution has an impact on the nature of the tumor. The more a tumor is dedifferentiated from a genetic perspective, they are more likely to be producing something more primitive, like, say, dopamine or something else like that. Whereas more advanced tends to produce more towards the right-hand side of the slide as well. So most Pheos produce, and this is taken from the Endocrine Review's article more recently, norepinephrine, mainly those in the extra-adrenal location. Many produce both norepinephrine and epinephrine, typically the adrenal tumors. And there are forms, particularly in certain forms of MEN2, etc., wherein epinephrine might kind of dominate in their production. And the more primitive ones, and this particular type that is more prone for metastasis, aggressive tumors, the STHB mutations, they produce only dopamine or much less of the other catecholamines. And therefore, the clinical syndrome that they present with is more florid. Hypertension may be variable. In fact, some of them do not have very severe hypertension in certain situations as well. And when you give them an antihypertensive, the blood pressure can actually crash in this situation. So what about silent pheochromocytomas? 5 to 20% of patients. And nowadays, that we are picking up patients who have more as incidental lesions. Many of these patients may have just mild hypertension, which may be coincidental and systemic hypertension, whereas the others, so therefore, we should be taking them equally sequentially, wherein the catecholamine levels may not be that elevated or may not be elevated at all, but they should be. Once you see the imaging features, they need to be treated and they need to be operated eventually. This rarer form of dopaminomas are just very briefly mentioning, and I mentioned about fact they do not have as florid hypertension as well. Sometimes when you use an alpha blocker like prazosin, you may have a hypotensive crisis in that situation. The rule of 10 is now obsolete. We used to talk about the 10% tumor, but things have changed. A vast majority in the West are being picked up incidentally. Some other cause, some other symptom for abdominal pain, multiple medications being imaged for hypertension, and therefore you find out a lot of them are incidentalomas over there, and that is from what our current guidelines tell us from the endocrine perspective. And adrenal Pheos, the proportion of malignancies in extra-adrenal Pheos is more. So long-term follow-up, annual follow-up is an absolute must in these patients, and that is what we need to look at. Okay, now this is work which is the combined efforts of our molecular endocrinology lab, Rekha Pai, and the work which is spearheaded by my colleague, Dr. Simon Rajaratnam, and published about a decade before. and tells us a lot about the kind of the kind of tumors that we see in our setup. So genetics has now come to stay and become the gold standard for diagnosing this test. And right now, as I speak, Asha and the team are actually doing a very good study, comprehensive evaluation of genetics of pheochromocytomas over here. We need to do genetics in all our patients. Now, when it comes to paragangliomas, when you have bilateral lesions, it is part and parcel of treatment because it will help in diagnosing multiple syndromes, and it helps in predictive screening at the next generation, making the diagnosis early and therefore making the prognosis better in these patients. So we have to now incorporate this into our armamentarium. 18-year-old lady comes with severe hypertension for 3 months. Norepinephrine levels are high, and there's a very obvious cystic-looking lesion, which is also enhanced at the rim with contrast on the right-hand side as well. There is also an additional tumor in the pancreas. So what is your diagnosis now that you see this? Most of you medicine PGs will know this is a patient with a pancreatic lesion plus this is a von Hippel-Lindau syndrome. That is the MIBG scan, the isotope scan, which is positive over here. I think there are bilateral lesions in this patient. So you need to operate on both sides. But the good news is that our surgeons, and that is why the team is so important, are so adept in this procedure that they will take off the tumor and the adrenal on one side, but the side which is smaller, they can actually spare the rest of the adrenal gland, and therefore you do not need to give lifelong glucocorticoid and mineralocorticoid therapy. Otherwise, you actually impose the patient on glucocorticoids and mineralocorticoids for life. And in case of stress, you need to give them hydrocortisone. And in a country like ours, if you're a remote area, you always worry about them crashing and therefore succumbing to such an adrenal crisis. So this is an option which we have in our patients. Histopathology, of course, is really important. And again, pathologists are so, and if you remember from your general pathology days, the typical Zellen ball in appearance from these patients that they have over here. As I mentioned, genetics has now come to stay and part and parcel of our diagnostic armamentarium. This patient with the clinical syndrome, it was pretty obvious. And she, on the Sanger sequencing, you can see over classical von Hippel-Lindau syndrome variant, which is there in this patient. So some patients may be absolutely, in terms of history, nothing at all. You draw a pedigree chart, you don't find anything. So there are patients who do have von Hippel-Lindau syndrome and apparently do not have any family history, because nowadays, in terms of an overall screening perspective, we are picking up more patients over here. This looks very intimidating, but I think it is important because if they have a vascular tumor in the neuraxis, could bleed anytime and cause sudden neurological deficit. So therefore, this protocol is very, very important and should be followed routinely in these patients. They could have a vascular lesion in the retina, very commonly, and that could suddenly bleed and cause sudden vitreous hemorrhage and blindness as well. So therefore, this is part of the protocol. We talked about cluster diagnosis in type 2 diabetes, and now there's even a cluster for and when we talk about the neuroendocrine tumors of the adrenal and as well as the paragangliomas, we have a cluster. I'm not going to go into too much depth, but they help in kind of classifying the conditions from a genetic perspective and also from a therapeutic perspective. So here we basically have first type, the pseudohypoxia type of clusters, one in A and B, which largely is this condition which I've talked about, the von Hippel-Lindau syndrome as well. If you look at the mechanism of how this actually happens in these patients, you have an increased tendency for angiogenesis. You have an increased tendency for growth because of, as you can see, the glucose transport over here as well. And therefore, you get tumor formation, which may be in multiple organs in these patients. Now, here's a 31-year-old gentleman. Nitin has given me this case a while ago with hypertension, palpitations, flushing, and headache. And you can see over here the blood pressure is elevated. Norepinephrine levels are pretty much high in this patient, and the urine metanephrines were normal. As you can see over here, large vascular irregular lesion over here on the arterial phase again. But this patient also has bilateral carotid body tumors, and the isotope scan is also negative. Now, these patients would require surgery. aggressive surgery even for the neck. And that is why the isotope scans play such an important role in diagnosis over here. The vascular surgeons are also involved over here. And you can see over here, subsequently on follow-up, a daughter PET scan shows residual lesions over there. The role of the nuclear medicine, the nuclear physicist also comes in over here, wherein lutetium therapy is given for these patients. Once again, Nitin had published the series as well. And we go on to the next group, the cluster 2 tumors over here, which we are talking about, which essentially involve the red proto-oncogene pathway, and therefore you're familiar with the MEN2 tumors, the neurofibromin tumor suppressor tumors. So very rarely you have patients who have neurofibromatosis. A very small proportion can also have a propensity for developing and other mutations, which are increasingly becoming important. And now with the advent of next generation sequencing, you screen the entire panel at one shot rather than individually doing Sanger sequencing for each gene. So a massive parallel sequencing for all these mutations at the same time. 44-year-old gentleman with a history of severe hypertension for 2 years and recent onset of diabetes. Urine metanephrines and normetanephrines are actually unremarkable over here. The hypercalcemia is present with a non-suppressed parathyroid hormone. You know your diagnosis is obvious. With the parathyroid tumor over here, also has on the MIBG scanning, you can see bilateral adrenal tumors on both sides. So this clinical symptoms and incidentally discovered 2-centimeter vascular adrenal mass. Pheo should be suspected even though the catecholamines are negative, and therefore these patients go through a pre-biochemical phase. We've had patients who have, the index case is one who has a Pheochromocytoma with bilateral tumors, and then you do the genetic testing. The daughter has medullary thyroid cancer. You operate it early, before the age of 5. This is the value of predictive screening. The mother will probably have done much worse coming with metastatic disease, but the daughter can actually have a predictive, a prophylactic thyroidectomy, and even a prophylactic adrenalectomy, as we screen the abdomen every couple of years, and that may be also done in these patients. So here is a patient, the patient actually, you can see the ultrasound shows a parathyroid adenoma, and you can see over here has had series of treatments, bilateral adrenalectomy. This is commonplace in patients with MEN2, wherein you may have to go through 2 surgeries, regular surveillance, but then it improves the prognosis tremendously when with our genetic screening and predictive screening that we do in these patients. This is the publication from years back. Much like the rest of the world, the red proto-oncogene screening which has been done here shows certain mutations, and some mutations have a worse prognosis. So even prognostically, the mutations can also help in these patients. So as I mentioned, prophylactic thyroidectomy and adrenalectomy, screening of siblings and children, friends of MEN2 when not very classically syndromic, and also the severity of the disease with certain codons, as you can see over here. The algorithm for management of these is more or less the same over the years, but CT scan is definitely more than enough for most of our patients, unless in very specific situations. We don't need an MRI. CT of the abdomen is very good enough. Isotope scanning, we're moving more towards the DOTA PET scans over here. MIBG is becoming actually difficult to get in many centers outside as well. And of course, the only cause for hypertension where you load them with water and with salt is a patient with catecholamine producing tumors. Because you want to prevent them from having a vascular collapse after surgery, you need to plasma expand them preoperatively, give them lots of salt and water. And we manage with prazosin more often than not because it's much cheaper, though the drug of choice would have been phenoxybenzene, which is seldom used nowadays. And minimum beta blockage is started after about 7 to 10 days of the alpha blockade as well. The tumors might be sometimes big, and therefore the surrounding organs may also have at times be injured or be operated upon, and therefore prophylactically we need to consider immunization in some of these patients. Nowadays, these are the standard anesthetic agents which are being used, so we don't need to worry. But when we were in an era where, you know, nitrous oxide and halothane and things were being used, much more provocative in terms of catecholamine secretion. But the anesthetists are so adept, they can handle these minimal surges. There are surges of blood pressure at the end of the day, even when you alpha block. but the anesthetists are very adept in handling these surges, and that's actually part of the treatment, that the anesthetist should be good in handling these problems as well. So very large tumors like this, shown to me by Dr. Paul, our endocrine surgeon team, has how they've actually resected them and done a wonderful job here. Where at times they do call in the urologist extra when there are multiple tumors or it's close to arterial structures extra in addition. So what is your diagnosis over here? Showing you a picture of a patient, there's a skin lesion. Look carefully at these CT scans and have them marked for you, and you can therefore try and make a diagnosis. Felix gave me this picture. What do you think? Anybody? Any ideas? Okay. So there's skin lesion over here, like an amyloidosis. There's a thyroid swelling over there, and you have an adrenal tumor over here. So this is MEN2B, right? This is MEN2B that you're dealing with over here. Medullary thyroid cancer, Pheo, and lichen amyloidosis, which you're seeing over here. 25-year-old lady, history of hemiperiphis after an intracranial bleed, married, conceived, had a baby which was born by LSCS, started complaining of headache, found to have high blood pressure and profuse sweating, and worsening of her symptoms after using the toilet. This is an age-old case, which I remember seeing with Dr. Sheshandri almost 30 years ago, 25 years ago. Right. Okay. Right. So interestingly, my hair has become gray and he stays evergreen thereafter. You can see over here this tumor inside the bladder. It's confirmed again here on an MRI scan and an MIBG scan, which has to be done delayed because MIBG anyway gets into the bladder through the urine, but you wait for a few days for it to be totally excreted, and then the bladder wall takes it up over there. This is classical. She went partial cystectomy, and she's actually still doing very well. I remember this lady from, I think, Coimbatore, who did extraordinarily well. And these are biopsy pictures showing these are actually extra-adrenal pheochromocytomas. More often than not, they're not in the bladder. They're actually in the parametrium around the bladder as well. And with early treatment, they can do fairly well. Finally, we come to the last cluster, the most exotic of one of them, of kind of an aggressive phenotype with a history of multiplicity, recurrence, and metastasis. They usually are, they seem to be non-secretory in most situations, and they do not have hypertension as a major. This is a 28-year-old lady, which I remember we saw some years back, came with history of postpartum fever to sort of be, puerperal sepsis, etc. subsequently. And then no other cause was found. She also had this polyarthritis at the same time. And when in her fever workup, everything was done. And imaging of the abdomen was then alluded to and found this huge lesion inside the liver and adrenal lesion as well. And the catecholamines essentially were negative here, but you see a vascular lesion like this. Think of a pheochromocytoma. Biopsy of the liver was done, showing a neuroendocrine metastatic lesion. And this is the isotope scan, MIBG, which was done. So basically a catecholamine producing lesion. Perhaps I shouldn't be calling it a pheo, and with hepatic and lung metastasis and paraneoplastic. She was given this treatment, glucocorticoids, octreotide. She had a full arthritis workup, by the way, from an autoimmune perspective. This is the initial MIBG scan. Subsequently, you can see a remarkable resolution of her thing with isotope therapy. This is the beauty of multidisciplinary treatment, which helps over here. And of course, nowadays, with the newer agents, the medical oncologists are also being looped in, but that is only for a subset. This is not a group of tumors which, by and large, you need medical oncology kind of intervention. It's mostly medical, surgical, the isotope therapy, which we use over here. So in summary, an attempt to look for a syndromic association with POs and is very critical. This is very important. It's part of the workup. Genetic testing is essential to identify at-risk siblings. Isotope scans are important, and our team working together is very important. I'll just end with one case just for completeness, because I told you that hyperaldosteronism is more important than POs. And I think this has to be in your outpatient. Once you see a patient, whatever the age group, once they're on 2 or 3 medications, first think of hyperaldosteronism as a very important cause. Even in patients who are established diabetics, more than 50 years of age, beyond renal artery stenosis, please think of hyper, which might coincide in these situations. And we're seeing more and more of this in our patients nowadays. This lady, once again, comes with severe hypertension, has grade 3 hypertensive changes, low potassium, hyperkalemic alkalosis, and ECG showing U waves, CT abdomen, lipid poor lesion, low Hounsfield density. So this lipid-rich region, rather with low Hounsfield density, this patient has a aldosterone-producing adenoma. So the aldosterone levels are elevated, renin levels are suppressed. You have hyporenemic hyperaldosteronism. In the old days, a lot of them used to come with periodic paralysis. That is the publication which came back in 1989, Sir Dr. Sheshadri's, on when the periodic paralysis presentation of hyper was a major presentation. Nowadays, of course, you don't see so much of it because all your patients are on ACE and ARB, and it all gets masked by the time they come to you. Many of them don't have hypokalemia. This is a classical example of a lipid-rich tumor after it's been excised over here with hyperaldosteronism. And the classical water clear cells that you see on pathology in the H&E staining. Jerome Cohn was a real visionary person because in his initial article in 1964, it's a long time back, basically, when he described the syndrome which is named after him, he talked about it that you may not have a low potassium in all situations. He also talked about them having coincident systemic hypertension, which is what you are actually seeing. And he also talked about incident cortical adenomas, and this must have been from postmortem findings, and this was in 1964. And all these things we know now today are important associations with hyperaldosteronism. So just a bit of percentages to tell you how common it is, 5 to 13%, 0.6% of adrenal incidental maybe more now as we look at these, 3% of hypertension in a primary care setting, and 39% with resistant hypertension on a long-term basis. You can manage a lot of these medically. That's important for you to understand. There's a proportion which you can manage with just spironolactone or epineuron in a good number as well. So nowadays we have other isotope scans which can be used, especially when you have bilateral lesions and there's ambiguity. There are isotope scans which can be used to help in identification of the condition. Just a brief word on familial hyperaldosteronism, that this should also be thought about. It is seen, it is not uncommon, and now we have an added reason to do genetic testing for predictive screening. We do have a number of patients who come with a young onset hemorrhagic stroke. The family history of hemorrhagic stroke. This is a clue to a kind of familial hyperaldosteronism we should be thinking about them. These patients may not always have a discrete lesion on the tumor, or may have ambiguous bilateral tumors in certain situations. Getting down to brass tacks and the basics, when we have young patients with hypertension, we need to have a workup in that direction. Think about your renal causes, have a checklist in terms of your history as well. Don't forget good old clinical examination, which is so very, very important in all your patients as well. And your baseline investigations have to be done. I'd like to thank our entire team who has helped over the years for handling our patients with these complex tumors. It's all teamwork, endocrine surgery, nuclear medicine, and many others in addition. Once again, like my colleagues invited you, we invite you for our meeting in the month of January. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Nihal. Again, questions we'll save for the